All right, thank you for staying with Daybreak. That conversation begins right now. We're talking about universal health coverage and also the cancer care in this country. What are the hits? What are the misses? It's been a month and 7 days since the launch to all the 47 counties of universal health coverage. We'd like to hear from you. What is your assessment at Trevor Mbij at Citizen TV Kenya? Use the hashtag Daybreak. Our experts with me in studio. Professor Olive Mugenda is here. She's the chairperson for the Kenyatta University Teaching, Referral and Research Hospital. Professor Kivutha Kibwana is also with us. He's the Makueni governor, is joining us live. Professor Graham Lord is also here, Vice President, University of Manchester, and also Dr. Joseph Lenai, Director, International Health Relations at the Ministry of Health. Thank you so much for making time for us this morning. And Professor Kibwana, I'll start with you as the governor for Makueni. What is your assessment of the universal health coverage that was now rolled out to all the 47 counties about a month ago? How far are we? What are the hits and what are the misses?
Thank you, Trevor, and all the colleagues on the panel. I think essentially what has happened now is particularly the registration of indigents who are already now going to be on the universal health care program. And these are roughly about 9,032,466, almost about 1 million, and that is in 26 counties. So 21 have to complete this exercise, and in phase 1, it is expected from the about 5.1 million indigents will increasingly be catered for. So that registration has taken place, and the NHIF has data of about 1.5, let's say, indigents, because that is really the first priority, to make sure that those who really can't afford, the state pays for them. Also, NHIF has, of course, empaneled all the health facilities. There are about 7,366, and of those, 5,803 are public facilities. NHIF is working towards standardizing payments, so that if you go to any hospital, private and public, they will reimburse the same, whether it is a level 4 hospital in a county, or private hospitals. But unfortunately, up to now, most of the monies that are paid by NHIF are paid to private facilities, although they are less than the public facilities. And part of this is because as counties, we are not still able to fill the claims properly. Also, make sure that in terms of capitation, we supply the requisite information. So there is still, in my view, the desire to ensure that members of the public realize that you can go to public facilities, and actually a lot of them, particularly in the rural settings, are better than private facilities. But still, people are going more to the private facilities, even when the doctors treating them in those public facilities are actually from the health factor. So one can say, therefore, in conclusion, that in summary, that we are at the initial stages of entrenching universal health care by, first of all, making provision for indigents, and also saying that everybody else should pay 6,000 shillings per year, 500 actually every month, 17 shillings per day. Yeah. And those who can afford can also go into the private insurance to supplement NHIF.
Okay. Dr. Lenai, what is your assessment in terms of universal health coverage? How far are we? What more needs to be done?
Thank you, Trevor. Thank you, Prof, also for that great input. What you find is that the call by the President in the Big Four agenda, what we are striving in UHC is to ensure that there is access of quality health services wherever they are needed by anyone, even up to the household level. After launching the UHC in Mombasa, as you saw last time, 6 more counties have been able to take over and launch, but we expect all the others that are remaining, around 40 of them, should be able to launch and own this process. So already Kajiado has done the launch, Kisumu, Kisii, Homa Bay, West Pokot, and Nandi just the other day. And what you find is that what Prof was saying, what are we focusing on? Of course, availability of healthcare services, whether specialized or middle or even preventive. And also what we are looking at, these services have to be of quality. And in addition, the financial protection has to come in.
Yeah.
And that's what we are focusing on. Now, there has been that call upon that we need to look at who are these who cannot be able to pay for themselves. The new NHIF Act, which is still undergoing public participation, calls for each and every person should be able to pay for NHIF. And for those who are not able to pay, we already have a database of what Prof is saying, the indigents. And these indigents are being paid for by the government. Already, the NHIF have gotten money from the government, which they are going to pay for around 1 million people this financial year. We expect to escalate that to around 5 million in the next 5 years. So the other thing counties are being told to look at is the issue of ring-fencing the monies that they collect from the facilities. You know, the president made the services in the dispensaries, the health centers free.
Yeah.
But level 4, 5, 6 are still charging. But where is this money going to? Into a common kitty in the counties. But what we are calling upon the county is to ensure they are coming up with modalities of ring-fencing this money so that it is injected back into the health system.
Okay. Professor Kibwana will come to you on that issue of ring-fencing the money collected there. But Professor Mugendi, what is your assessment? What do you think needs to be done now that you are running the KU Teaching and Referral and Research Hospital?
Thank you very much, Trevor. I think what we need to do is to make sure that we make the healthcare accessible in terms of cost.
Yeah.
And, you know, as you know, we were able to get, you know, one of the key machines, equipment that is able to detect cancer very early.
Yeah.
And our contribution is that the patients who are coming for scanning, instead of going to India, as long as they are the NHIF, we are not asking them to pay anything. So they're paying, for example, 40,000 for that service, and they don't have to add anything. And we feel that that's a major contribution because it means anybody, as long as you are the NHIF, you don't have to pay anything for that service. And it's a key service for Kenyans, Trevor, because so far, for the last 2 months that we have been scanning patients, we have done 300 of them. All these would have gone to India. 300 of them, because this machine is only is available in KU, in a public institution, not just KU, Kenya, East Africa, Central Africa. So we are also seeing people from the region. So you know, for us, that's a major contribution, Trevor, to universal healthcare. Yeah. And I think the bigger picture is that not just for the scanning for the cancer, but all other services. If we can make sure that whatever is being paid by NHIF is what the patients are paying without adding, I think we'll be able to help more Kenyans. Okay. Yes.
So I find that interesting. So if I want to be tested and see for early detection of cancer, all I need to do is walk into KU, or how does it work?
Yes, you just, of course, you have to be referred. Yeah. Because this is a very specialized machine. Yes. It's called a PET scan, Trevor, and I think it's good Kenyans to know that they no longer have to go to India for this machine. You have 2 of them. So the waiting period is also, you know, very short. But if you want to be scanned, you have to be assessed by your doctor, referred to us, because the doctor must suspect maybe there's something. You can't just walk in when you are healthy and have tested. Yeah. So the doctor suspects something, you know, of course, through their own professional knowledge, they send you to us, and you just book. We get the approval from NHIF. Nowadays, it's very fast. You can get approval in a day, and we book you in. Some are coming the same day, Trevor, and getting scanned. Okay. Or maybe the following day. Okay. Yes.
Professor Graham, what is the best practice in the UK? How does this work? How does the healthcare system work? Is it affordable for the people? What is the system there?
Well, good morning, Trevor, and your viewers, and it's great to be here. I'm sort of representing the UK as part of the Kenya UK Healthcare Alliance, Health Alliance, and we've been working together for the last 2 years. It was formally launched by the President last year. In the UK, we have a system called the National Health Service that was founded actually in 1948, where healthcare is free at the point of use. And it's paid for by the government. So sort of similar principles, a slightly different economic arrangement to UHC. Yeah. So as I said, we've been doing that since 1948. UHC, I think, is just over a month old. Yeah. So I'd say hits and misses is very, very good. I think UHC as part of the Big Four agenda is absolutely transformational in access to healthcare for the whole of the Kenyan population. And I guess what we're trying to do is help work together in partnership with the Government of Kenya and Ministry of Health and with Kenyatta University Teaching Research and Referral Hospital, as you say, to see what does best practice look like. Also with the Christie Foundation Trust in Manchester, which is one of the best cancer hospitals in the world. Yeah. We're working very closely with Professor Magenda and her team at KUTRRH to ensure that the treatment is world class, so people again can stay in the country. Yeah. They get access to the best treatment available around the world. And in fact, we had a tour of the hospital, I think, on Tuesday, and the progress that's been made there has been absolutely amazing. These new machines are state of the art. The imaging centre for prevention and early detection of cancer is as good as anywhere in the world. Yeah. And the progress that has been made in Kenya over the last few months has been extraordinary. And essentially coming in from the UK, this gives us an opportunity to benchmark the quality of care. And I have to say it's been very impressive treatment. Yeah. The one thing I would say is the focus on early detection is really quite important. In Kenya, 7 of 10 cancer diagnoses are made at a late stage, and we know at a late stage of cancer is much harder to treat, and so the mortality from cancer in Kenya is very high. And in the NHS for many years now, and it's not easy to do, we've been focusing on prevention of cancer and early detection, as we spoke about, because if you detect cancers at an early stage, it's much more likely to be curable rather than at a late stage. Yeah. So I would say in summary, this is a long journey. UHC has been there for just over a month. Great progress, but actually further to go.
Yeah, and that is where the rubber really meets the road, prevention and early detection of cancer. And you've talked about a partnership between yourselves and KU. Give me more details about that. So how is it supposed to work, and what is the end game of this partnership? So is it that we'll refer people to the UK, or how does it work?
No. So I guess the two major challenges we're working on is if you like, the rise in the incidence of cancer. So if you want me to give some numbers, in the last data we have is 2018. Yeah. So about 47,000, 48,000 patients in Kenya diagnosed with cancer, and there were 33,000 deaths. That has risen by almost 30% since 2012, the incidence of cancer, and it's projected to increase even further over the next few years. So cancer, we call it a non-communicable disease. Yeah. That's going to grow. So how do we manage that? And again, that's partly about prevention and early detection. The other thing that the partnership is working on, and I was in Kisii County the previous 2 days, launching a centre of excellence in healthcare, education and training, is do we have the workforce to deliver these changes in healthcare? So there's one thing having the facilities, which are very, very important. You then need a multi-professional workforce, doctors, nurses, other allied healthcare professionals to provide that treatment. The one specific example I'll give about, as you say, where the rubber hits the road, what are we doing in partnership? We just received a grant from a UK funding agency to look at esophageal cancer in Kenya, in partnership with Kenya. Most of that money is coming into Kenya in partnership with investigators at Professor Magenda's hospital, and also in Kisii County, and actually in many counties around the Lake Region Economic Bloc as well. Yeah. We know that if you're diagnosed with esophageal cancer, the mortality rate is 99.7%. So, because it's very often detected at a late stage. So what this research grant is doing is understanding what the causes of esophageal cancer are, how we detect that early by going out into the community, and then critically what treatment works for patients of Kenyan origin rather than from patients of British origin, for example. Are the treatments that we use in the UK the right treatments for people in Kenya? esophageal cancer is only the start. We're going to be working on breast cancer, cervical cancer, and transform the infrastructure so that we are focusing more on early detection.
Yeah.
And of course, prevention is an important message for public health around avoidance of, smoking, for example, for lung cancer, and other things that we know are carcinogens.
Okay, let me bring in Professor Kibwana back on this. And Prof, when we talk about UHC, we are talking about 3 essential pillars, and one of them has been mentioned by Professor Graham there: affordability, accessibility, and the quality of healthcare. Let's start with affordability and talk about that. And also one of the things that Joseph Lenai had brought up is the issue of counties ring-fencing money that they collect from their facilities. How do we ensure that healthcare is affordable to the people?
Thank you very much again. Let me start by giving a very, I don't know whether to call it rudimentary example, but in Makueni, as is probably common knowledge in the country, we devised our own system of universal healthcare where people began to pay 500 shillings households, and they would be registered, and they would actually receive most of the services free of charge thereafter. And this we started in September 2016 up to now. And the reason we did this, we said, how much money was being paid to the hospitals. And it was about then roughly 100 million shillings. And we said, therefore, if we get the equivalent from our 250,000 households, we will be able to sustain a universal health program according to us. And indeed, actually, whether people are going inpatient, whether they are being operated on and all that, essentially they don't pay, apart from very specialized services like, cancer treatment, where we will charge them a subsidized amount, dialysis, and so on and so forth. And for us, it worked, and that told us that universal health coverage is actually possible even at national level. And I think perhaps some of our work inspired the country toward the universal health coverage. So there was affordability, because we made sure that we made the facilities more. For example, we started with 3 theaters. We have now 14. We started with about 109 facilities. Now we have about 238 facilities. So, and the staff and the money you dedicate to drugs and so on, the drugs are one of the most critical areas, and there sometimes there are challenges. But we also realize that you must you must ensure that people get into NHIF so that it supplements what you have as a domestic universal healthcare program. So that affordability, and I think that is what the assistance the government is giving to indigents. And for example, in what Raila Odinga is proposing, the Baba Care, this idea that when the indigents get like 6,000 shillings every month, from that sum, they'll be able to pay health insurance, and when you collapse national health, NHIF schemes, Minister of Health programs, social protection by labor and social protection, you have the base for making sure that this is affordable. Because if it isn't affordable, accessible, and in quality, then it isn't really like we had the example of the UK system, where as a student I benefited from it, and it was really positive, but it's always expensive, and so one has to look at that expense. And finally, the ring fencing. It means that money which is paid like through NHIF, through Edu, Afia, through Linda Mama and all that, all the money that you get, and including in our situation, money for the 500, now 1,000 shillings, you need to make sure that it goes into improving the facilities, not to be put in the common pot, where now it will do roads and so on and so forth. But there has to be a proper legal provision for that, because even up to now, we get asked by the Auditor General when that money is not put in the general pot. We keep on being asked what is the legal provision for what you're doing. So it's very, very critical. That aspect is streamlined so that nobody is taken to Auditor General and so on when they are doing the right thing.
All right. Dr. Liana, you've had the response from the government. It's just a matter of streamlining the policy. But let's talk about these pillars one at a time. So we're starting with affordability, and you talked about NHIF. Is that the silver bullet, or should we marry that with also private insurance at the same time?
What you realize is that the whole goal of the Ministry of Health is to ensure the care in Kenya is equal or less than that of India when we look at it from the bigger perspective and what we are doing.
Yeah.
Now, there is a lot of medical tourism happening, people going abroad for medical treatment.
Yeah.
Now, what have we done? We have made sure all the associated costs, and so we are cutting by availing some of the specialized things that you are hearing about KUTRH. And in addition, when you look at issues of affordability, you're looking at the reforms that we are doing in NHIF. One of the things we are doing at NHIF is looking at the package that we are offering. Of course, earlier on, before the reforms, there are some services that people were paying for.
Yeah.
But currently, we are looking at a comprehensive package where all services that are offered can be taken care of by the NHIF. So affordability, even if you have services and it's accessible and people are still paying out of pocket, still UHC cannot be achieved. And that's why we are looking at the issue of making sure financial protection is there. Of course, the issue of looking at whether the private can also be available. Currently, we are looking at NHIF being the best buy in terms of affordability.
Yeah.
The private is, of course, a bit expensive when you compare. And as Professor said, for the NHIF, you just have to pay 6,000 shillings, which is 500 per month, which is like 17 shillings or an egg per day.
Yeah.
So it's quite much affordable. But you see the government has taken deliberate move, looking at even those, the poor of the poor, using the data that we have and are paying for them.
Okay. Let me take a quick break here and come back with Professor Olive Mugenda and Professor Graham on this issue of affordability. But keep your views coming at Trevor Mbija at Citizen TV Kenya. Use the hashtag Daybreak. I see some of your questions already. We'll post them to my panelists in just a short while.